Good morning. Today we'll have surgical audit discussion for MR Bangalore Hospital for the month of September. We have 3 units and 3 presentations. The presentation from Unit 1 will be by Dr. Mehul Patel, who is a first-year junior resident at MR Bangalore Hospital. Mehul will share the surgical audit of Unit 1 General Surgery under Dr. A.K. Kaur and Dr. Ronit Roy.
Good morning, everyone present. I'll be presenting audit for this month of September for Unit 1 General Surgery. Total number of OPD days 8, total number of admission days 9, total number of OPD patients 901, total number of new patients 525, total number of old patients 376. Total number of elective OT days 9. Total time planned in OT was 38 hours 20 minutes, in lab 25 hours 15 minutes, and open 13 hours 5 minutes. Total number of minor OT days 11, time spent in minor OT 12 hours 40 minutes. Total number of mortalities 2, total number of morbidities 1. Total elective admissions were 43, total emergency admissions were 30, total elective operations were 38, total emergency operations were 23, total minor operations were 16, 2 mortalities and 1 morbidity. For case of chronic calculus, 14 cases of chronic calculus cholecystitis for which laparoscopic cholecystectomy was done. 1 case of type 1 Mirizi for which laparoscopic subtotal cholecystectomy was done. 1 case of chronic calculus cholecystitis for which lap was converted to open cholecystectomy, and 1 case of distal pancreatic laceration for which distal pancreatectomy was done. In gastrointestinal perineal cases, 3 cases of anal fissure for which lateral anal internal sphincterectomy was done. 1 case of fistula in ano for which fistulectomy was done. 1 case of fistula in ano for which lift procedure was done. 1 case of internal hemorrhoid for which hemorrhoidectomy was done, and 1 case of recurrent appendicitis for which lap appendectomy was done. In hernia and groin surgeries, 3 cases of unilateral inguinal hernia for which herniaplasty was done. 2 cases of paraumbilical hernia for which anatomical repair was done. 1 case of congenital hernia for which herniatomy was done. 1 case of mesh infection for which mesh extraction was done, and 4 cases of phimosis for which circumcision was done. In breast and endocrine surgeries, 2 cases of fibroadenoma for which excision was done, and 1 case of surgery thyroid nodule for which hydrothyroidectomy was done. In emergency operations, 2 cases of hollow viscous perforation for which expiratory laparotomy with modified Cullen-Jones repair was done. 2 cases of 1 case of obstructed ventral hernia for which exfiltrated laparotomy with the resection of strangulated tooth followed by a double barrel ileostomy was done. 1 case of intestinal obstruction for which exfiltrated laparotomy followed by ileocolostomy was done. 2 cases of appendicular perforation for which exfiltrated laparotomy with appendicular base repair and loop ileostomy was done. 3 cases of diabetic foot ulcer for which debridement was done, and 2 cases of gluteal abscess for which ID was done. 2 cases of acute pancreatitis conservative management was done. 3 cases of acute calculus cholecystitis for which conservative management was done. 3 cases of acute appendicitis for which open appendectomy was done. 2 cases of subacute intestinal obstruction for which was conservatively managed. 2 cases of foot cellulitis with compartment syndrome for which fasciotomy was done. 3 cases of diabetic foot ulcer for which debridement and dressing was done. 2 cases of rectal prolapse for which 3 years procedure was done, and 1 case of corneal gangrene for which debridement was done. Total minor operations were 16. 2 chest insertion were done, and 1 postnatal biopsy. 2 postnatal biopsies were done. Morbidity 1 morbidity and 2 mortalities. First mortality, a 72-year-old female came to the ER with features of intestinal obstruction. She was a known case of hypertension and diabetes with a history of 5 days. She had a history of previous expiratory laparotomy 30 years ago with no reports or detailed histories were available. WBC count was 22,000, saturation was 93% in Boomed, and BP was 100/60, and pulse was 121 per minute. So, it was resuscitated, and exploratory laparotomy was done. Multiple addition plans were noted. They were released. A part of the ileum showed discoloration, for which resection was done, followed by ileocolostomy. Intra BP was 70/50. The patient was shifted to ICU immediately from the OT, where her BP was 65/40 on NORAD support. She was intubated and a cell count shows a count of 26,000. FFP was transfused on POD1. The patient succumbed to that due to sepsis and severe metabolic acidosis. Second mortality, an 85-year gentleman came in the ER with features of hollow viscous perforation with a history of 7 days. The patient was in sepsis. He was immediately shifted to the OT and exfoliatory laparotomy was done. It was a case of T1 perforation for which saline zone repairs were done, and the patient was shifted to CCU. In the post-operative days, the patient was disoriented and villous gastric output of around 1800 ml was there every day. POD7, the patient was not maintaining saturation and BP, so he was put on ORAT support and was ventilated. And he eventually succumbed to death on POD9. Morbidity. A 70-year-old gentleman came to the ER with pain in abdomen. He had a history of fall and blood trauma to the abdomen 1 week back. His vitals were stable. CCT was done, which showed distal pancreas restoration with ascites. Patient was resuscitated and a distal pancreatectomy was done. On POD1, the pancreatic bed drain was given. The pancreatic bed drain output was 300 ml. And the vitals were stable. The patient recovered well in the subsequent days with a drain output of 200 ml till POD7. Drain fluid amylase on POD3, 5, and 7 was 1.5 lakh units, 89,000 and 56,000 units respectively. It's POD15, the patient is ambulating, taking normal diet with regular bowel movements. Count is 10,500 and vitals are stable. Drain output is still around 100 ml. The patient is still on post-op monitoring.
Okay. So, go to the mobility part. It was a case of pancreatic injury.
Yes, sir.
What was the mechanism of injury?
So, the patient was preparing for army sir, they have to go for races, sir. Army recruitment. Okay. So, while they're training, one of the participants he fell, and this guy was behind him. He fell on them, and he got injured with
In a trauma scenario, what was this procedure done? Was it a spleen conserving pancreatectomy or splenectomy plus?
No, sir. Only distal pancreatectomy.
They could conserve the spleen.
Yes, sir.
Now the patient has got a pancreatic fistula. So how did you manage the proximal stump?
So the proximal stump was closed with the protein.
Probably. You could identify the duct separately.
Yes, sir.
The duct was closed separately.
Yes.
No, sir, we couldn't find the duct properly, sir.
Yeah, Ronit.
So the duct was not properly identified because there is huge adhesion, and it was more or less the patient presented to us on POD on 6th day of injury. So he could not identify. Yes, sir.
How did you manage 6 days?
They have referred the patient here and there in CT scan. It was if we can show you the CT scan, you will see that there is typical pancreatic laceration. In the report, it was also suggested it is a pancreatic laceration, but they have referred the patient from here and there. It was also referred from PG.
What was the site of this laceration? Is it the neck? Usually the common site for injury is the pancreatic neck area which got transected.
No, sir. The lacerated part was distal to the neck, and the bed was.
My point is, it's a laceration, and you could identify that there is no ductal leakage. Even a
Sir, pardon, sir. Hello. Hello.
Yes, Ronnie. Yes.
Sir, I couldn't get you, sir. Can you please repeat?
Hello.
Hello.
Hi, hello.
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 Yes, sir.
Hello, Dr. Kaur.
Hi, Dr. Kormulun. Yes, please.
Yes, actually, there was we thought there was a laceration, but the distal part of the pancreas, that is the tail of the pancreas, was simply transected. Through and through, there was transection. So
It was in the
there
tail,
was,
not in the body.
yes, yes, not in the body, but in the tail. That was there was a through and through transection of the tail. So we had to remove the transected part, and we sutured the distal part of the pancreas with proline, 20 or 30 proline, and we put a drain at the tail of the pancreas and 2 or 3 drains in the abdomen. That's it. And I would like to invite, I would like to invite suggestions from you. What could have been done otherwise?
See, the transaction usually occurs near the neck. Transaction,
Yes.
the tail is not very
Yes.
common.
Yes.
So that part is a distal dissection with either with spleen or without spleen. Okay. So if the duct is intact, there is only pancreatic parenchymal laceration.
Yes.
One treatment can be just drain and come out. You see, even with resection, this patient has developed a pancreatic fistula. We could not prevent the pancreatic fistula even with a distal. So you see, this is a classic example of pancreas. You are giving the patient octreotide. No, it still has to be given. You see, you need at least 10-12 days of octreotide therapy because still the output is more than 100 and it's all amylase in the fluid. So he should be on octreotide. The ideal treatment is resection. If the duct is intact, only parenchymal laceration, one can go with some debridement and repair and drain.
Yes.
Sir, sir, intraoperatively, the pancreas is through and through transected, and the distal portion is quite necrotized.
Yes. But I am wondering, you are saying that it's in the tail. Usually,
yes, sir, it is
after a fall,
far distal from the neck, sir. It is more or less some distal to the SMA and SMV origins.
It is better if you can identify the duct separately on the proximal side. If you could close the duct separately with a suture, then the chance is a little less. If you just give a overrunning suture on the cut end, the risk of leakage is more.
Okay. Because it is a 7-day injury, old injury, the bed was quite high-growth and.
You see, you're writing the patient was immediately shifted to OT. At what status? Patient of 7 days perforation, sepsis. These are the patient who needs optimization before shifting to OT. Even if there is a perforation, you cannot rush the patient within 2-3 hours time. So what is the optimization in this patient?
The patient must have an adequate fluid resuscitation.
How did you confirm that yes, patient is adequately hydrated? That's what I'm trying to know. Whether the urine output was established, whether the patient's blood pressure was stabilized, how was the pulse. So because if they are the patient, we have a lot of such patients in MR Bangalore, and these are the patients who are dying in the post-op period. So spend some more time to optimize these patients. Even if the patient is wait for 6 hours, nothing happens. You should be at least satisfied that these patients are adequately hydrated. The urine output is optimal. You see, these are the patients who are dehydrated. Our CCU people have the idea, start the patient on NORAD. No, this harms the patient. If the patient is not adequately hydrated and you give the patient NORAD, this causes more vasoconstriction in the visceral bed. I see this patient, if he was optimized, the patient on same day he was shifted to CCU. Yeah. And I'm talking of this NORAD support. The NORAD support, you should be satisfied that patient is. Have you done central line for this patient? How was your CBP? Because these are things one should look for. In a surgical patient who has got a volume loss, the volume loss has to be replaced first, then giving the patient RA NORAD. If the volume loss is replaced, yes, you have to give the patient NORAD because patient already has associated sepsis. First mortality. What is ileocolostomy here? Which part of ileum was discolored? You see, if you say discolored, discoloration does not always mean it's a necrosed body. Discoloration means there is a possibility that this might come back. What maneuver you did in the table? No peristalsis return, pulsation not return. So on resection, why could not do a small gut to small gut anastomosis?
Because the patient was.
No, you did a ileocolostomy, na? Means what? I mean, I couldn't make out. You have done a small gut dissection. Why ileocolostomy come?
As a patient was previously operated and a part of the colon, part of the.
Then you bring both the colon and the small gut outside. You reach the small gut. You did a hemicolectomy.
So she was already operated and
Operative. Who was the surgeon?
Sir, intraoperatively, the patient has got a gangrenous bowel in the distal part of the ileum. So we did a limited colectomy for this patient. And
That is asking. You did a colectomy. How can you do the ileocolostomy? If you have confined your operation only to the small gut, it will be a stoma in the ileum. You're saying I did ileocolostomy, then probably part of the colon was also taken out.
Yes, so the distal part of the colon has been brought out as a mucous fistula and the ileostomy has been done. And we did a limited colectomy and the stoma was done.
The gangrene was involving almost the IC junction?
Yes, sir. Not exactly in the IC junction. The cecum was found to be unhealthy. So we thought to proceed for a limited colectomy for this patient.
Go to the hernia list. This paraumbilical hernias, what is a hernial defect?
1 into 1 second.
Only. Why a patient needs surgery for that? A patient has got a 1 centimeter defect. Why the patient should need a surgery? Cosmetic vision. Okay. Fine. What about this fibroadenomas we discussed last day also? We should keep on thinking that most of the fibroadenomas regress spontaneously, number one. Most of the fibroadenomas respond well to synchroman therapy.
So they were given
No, I'm trying to understand the profile with the patient. Even if the patient does not respond to synchroman and the lesion are around 2.5 centimeter or less, on long-term follow-up, most may be better. I'm trying to understand that patient profile. If it is 30 years, yes, I will agree that patient might undergo surgery. What is the patient profile? Ronit, what is your strategy for fibroadenoma?
Sir, up to 3 centimeter, we can wait and watch. More than 3 centimeter, we excise. But in case of more than BIRADS 3, if it is less than 3 centimeter, we have if we have some confusion, then we can go for excision. But up
if
to
you have BIRADS 3, you can go for true cut. There is no harm to go true cut for
in BIRADS 3, we can go for true cut, and up to 3 centimeter, we can just wait and watch or give Centroman. Beyond 3 centimeter, we generally excise.
Particularly young patients. Particularly young patients. In young patient, there is a role for because I find in Bangalore there are a lot of patients with fibroadenoma who are getting excised.
No, so there is no point of excising a fibroadenoma of 2.5 centimeter or 2 centimeter in a
Upfront
40
to
years
2.5
old lady.
fibroma, young patient.
Yes.
Because most of the time these fibroma regress on spontaneous follow-up.
Yes, sir. Yes, yes, sir.
What are the solitary thyroid nodule histologically? Okay. Next will be presentation of Unit 2 by Dr. Shoham Samanta, first year junior resident at Unit 2. Milind More, you have joined?
Yes, sir. Yes, sir. I am here,
Okay.
sir.
Okay, fine. Good morning, teachers, seniors, and everyone present here. I am Dr. Soham. We are going to present surgical audit for September 2023 of Unit 2 General Surgery under Dr. J. Roy and Dr. M. More. There were 55 elective admissions, out of which 31 were male and 24 were female. Emergency admissions were 35. Elective operations were 53. Emergency operations were 27. Minor operations were 12. Mortality 1. Morbidity 1. Outpatient summary. Total outdoor days were 9. Total admission days were 10.
Slide is not changing. Soham, slide is not changing.
Yes,
Slide
slide
is
is changing.
fixed.
Yeah. You
Continue,
can see the
Soham.
change slide. Outpatient summary. No. Total OPD days 9. Total admission days 10. Total OPD patients 1012. Total OPD patients new were 698 and total OPD patients old was 314. OP summary, total number of where you are getting this data of new and old patients? From the register outdoor. Our OPD has got a register? All new patient comes. How did he enter? They give the follow-up patient. No. When the patient comes to the room, they come in small sleep. We go to the computer, we bring out the report. How joint to get that information? The man was not going to join. Actually, that has changed for the last 2-3 weeks. Because at present, Zanpida is not there anymore. Because it is coming, like this was an approximate data. Because you cannot give approximate data. That is wondering. Because the Monday OPD is more in number always. Because Monday is the maximum patients. I find is going beyond Monday. So you see, there are two ways of getting the data. One is in the central computer, where people are getting the ticket in central computer. They have got a data on today how many OPD tickets are made. So it's getting closed at 2 p.m. And some online tickets are done earlier also. So that all goes to this OPD ticket. You can talk of old ticket, even the old tickets are also entered. Yes. Yes, yeah. So you have to, Milind, you just find out this part. This data has to be correct. Now he's saying it's approximate data. How to get an approximate data? We used to that because we have to take with the ticket. Now they come with the small kids. The small kids go to each rooms. And in each room, I make the advice, not all patients are going back to joint for entry. So joint register is not adequate. Adequate is my computer entry. When I am entering in 3 computers on particular day, so total number of data in a particular computer will be the total number of patients seen. Now to find out the new and old tickets will be again the central computer. When they are putting the new number, that is a new ticket. And they are putting same date on the particular previous number, that is old ticket. इसको mechanism देखो क्या है? Ask the computer people, how do you get an exact data? How many tickets are made on Wednesdays, new and old? They might say, I cannot give you. कुछ तो होना चाहिए ना? Then you have to find out a way to make a calculation. Because at the end of the day, we can count. समझे ना? Whatever data I am entering in my room computer, at the end of the day, that will show how many data are entered. So you take 3 computer data, that is today's questions. How to differentiate old and new? That I'm saying, na, in the central computer, when they are going for a old ticket entry, they are giving a number. So when that number is given, they are entering that name as a re-entry of old ticket. That is there in the central computer.
OT summary, total number of elective OT days were 8. Total time in the OT plan was approximately 50 hours and 20 minutes. Table 1, laparoscopic surgeries were around 33 hours and 15 minutes, and open surgeries were 17 hours and 5 minutes. Total number of OT days in minor OT were 8, which was approximately 5 hours and 40 minutes. Total number of mortalities were is 1, and total number of morbidities 1. Elective admission under biliary, pancreatic, and splenic surgery. There were total 14 chronic calculus polycystitis cases, out of which 11 were performed laparoscopically and 3 were performed by open cholecystectomy. There was 1 case of biliary peritonitis for which diagnostic laparoscopy and evaluation of myeloma and pelvic collection was done. In gastrointestinal and perianal surgeries, lateral anal internal sphincterotomy was done for 1 case of anal fissure. Post fistulectomy was done for 4 cases of fistula in anus. 1 hemorrhoidectomy for internal hemorrhoid, and 3 laparoscopic appendectomy for 3 cases of appendicitis. There was 1 case of subacute intestinal obstruction for which diagnostic laparoscopy and anesthesiologist was done. In hernia and groin surgery, for unilateral inguinal hernia, 5 cases of unilateral inguinal hernia, herniorrhaphy was done. For 4 cases of umbilical hernia, anatomical repair was done. For 2 cases of congenital hernia, hernioctomy was done. And Jabulus procedure was performed for 3 cases of hydrosis, and anatomical repair was done in case of 3 epigastric hernia. And for 4 cases of stenosis, circumcision was performed. And there was 1 case of bilateral hydrocele with unilateral testicular mass for which bilateral orchidectomy was done. And in other surgeries, 1 foreign body extraction from the right hand was done under C-arm guidance, and excision of granuloma from right breastbone and left index finger was done. In emergency operations, debridement and dressing for diabetic foot ulcer and leg ulcer was done in 3 cases. Incision and drainage was done for 1 case of gluteal abscess, 1 case of breast abscess, 2 cases of perianal abscess, and 1 case of submandibular abscess. Fasciotomy and debridement was done in a case of cellulitis, along with compartment syndrome of the unilateral leg. Fasciotomy and debridement was also performed for cellulitis and compartment syndrome of forearm and hand. Open appendicectomy was done in 4 cases of acute appendicitis.
Incision and drainage along with detachment was done in a case of pyogenic tenosynovitis of unilateral index finger. Incision and drainage was done in excision was done of 2 cases of ruptured sebaceous tube. Herniatomy was done in a case of irreducible congenital inguinal hernia. Appendectomy with fecal repair and proximal loop ileostomy was done in a case of peritonitis. Incision and drainage was done in one case of total abscess. There was total 8 admissions for which conservative management was done, out of which 2 were acute Gaussian pancreatitis, 4 cases of acute calculus polycystitis, and 2 cases of subacute intestinal obstruction. In minor surgery, there was one clinical biopsy was taken from a breast mark. Morbidity 1, mortality 1, both female. Mortality, a 70-year-old female, known case of bradyarrhythmia with a pacemaker for 3 years, with a BMI of approximately 38, was admitted for elective open cholecystectomy. Intraoperatively, dense adhesions were noted around the gallbladder. Considering her comorbidity, she was kept in the CCU for 4 days. On postoperative day 1, 50 ml bile tinge collection was noted in the abdominal state in hepatorenal pouch of Morrison, but otherwise patient was doing well and thus the patient was being treated conservatively. 30 to 50 ml of bile was noted in the ADK every day for the next 4 days, but the patient was asymptomatic and the USG showed localized collection in the right hypochondrium. On POD 6, he was shifted to the ward, and within an hour of shifting the patient to the ward, 800 ml bilious collection was noted in the ADK. But the patient still did not have any complaint and her abdomen was soft and tense. Then at night, the patient complained of shortness of breath and drop of oxygen saturation and blood pressure was noted. She was treated symptomatically and immediately shifted to ICU, where she became unresponsive within half an hour and was intubated. Despite all possible treatments, she deteriorated and patient developed sudden cardiorespiratory arrest and succumbed to death within 2 hours of intubation. Morbidity. A 68-year-old female with no known comorbidities was admitted for elective cholecystectomy for chronic calculus polycystitis, and the surgery was performed 2 days after her admission. On postoperative day 1, there was 700 ml bile tinge collection in ADK from hepatorenal pouch of Morrison, but otherwise the patient was doing well. The patient was being treated conservatively. On POD2, there was 450 ml of bile tinge collection in ADK, but the patient was stable and conservative management was continued. On POD3, there was 100 ml of similar collection with mild guarding, but there was no complaint from the patient. USG showed minimum collection in HRTM and pouch of Duffy. On POD4, diagnostic laparoscopy and peritoneal lavage was performed and another drain was placed in the pelvis. After 5 days, there was minimum collection in both the drains, and thus the drain in the HRTM was removed the same day, and the other one was removed the following day. The patient was discharged on postoperative day 11.
Go to the mortality one. Dr. Milind,
Yes, sir. Yes, sir.
you have seen the patient? No.
Yes, sir. I had seen on emergency days when I was giving rounds, sir. I've seen the patient at that time, sir.
No, actually, what was is just said in a dense adhesion? Was the calories identified? Was the formal ligation?
No, sir. OT days, sir. I was
nothing
not.
was done.
The callus was densely adhered, and the posterior aspect of the gallbladder were adherent to the liver.
It will be on the liver bed only. So, how could you manage the calories area? Because the idea you see, in 1 month time, there are 2 incidents of bile leak following lap coli is quite high. If you've done 15 or 16 cases and 2 patients has bile leak, we consider this as a very high leak on the biliary leak cell. So I want us to review how we can think about it. We can take steps to reduce. So in this patient, if the calories was difficult, then you take some other bailout procedure. So I'm trying to say, what is the bailout? You could remove up to the cystic duct Harpens junction, or you remain towards the gallbladder neck. Because if the cystic duct area is, callus area is frozen, then it is wise not to go around that area. It should be safe, keeping towards the gallbladder neck side. And this patient was draining bile, I agree. But the patient who has drained 800 ml of bile on shifting, he was absolutely well, is difficult to make out. Patient has got 800 ml of bile in the peritoneal cavity, we have some discomfort.
So, the patient denied any ambulation while he was in the.
No, ambulation is different. But my point is, you see, you are seeing 15, 20, 30 patients over a month for gallbladder surgery. What I always try to say is, patient who is not comfortable on first or second post-op day, something is wrong. Okay, this patient required to keep in ICU for 4 days. And then this patient was draining about 40, 50 ml of bile. That is also not normal for our patient setup. So if you have a suspicion of bile collection in the peritoneal cavity, what investigation, what was done for this patient?
So USG was performed.
How do you think USG helps us in assessing bile collection? Very ill sensitive. If you have a suspicion that this kind of bile leak and not progressing well, one has to do a CT scan. If you have done a CT scan, this amount of bile collection would not have been missed. You see, most of the patient of bile leak dies because of sepsis and the biliary collection. 800 ml of bile come in the drain. A similar amount was there in the peritoneal cavity. So we have not been able to address that bile collection. So that bile collection has to be taken care of. And if the patient is not responding well in the post-op period, you see, no patient stays in the ward for more than 2 days. This patient stays for 4 days, in the ward again for another 1 or 2 days. So something is wrong, and he's not progressing as he should go in the immediate post-op period. So these are very important area we should take. We are doing, if we combine 3 units, we are doing at least 50 to 60 gallbladder in a month. So out of this patient, out of 60 patients, 1 patient should leave, or maybe less. The risk of biliary leak and bile injury is not 2% now, less than that. So we should be trying to take measure that how could you prevent this bile leak. Our unit also same problem. We had a patient of bile leak. Sister was torn. We could try to manage that, but there was leaking. But we have taken some steps to go ahead with that. Okay. All hernias are under repair. You don't find any hernia which is 4 or 5. All are 1 centimeter. Same hernia. Because you see, standard of care for hernia repair is mesh repair.
This month there has been already 2 repairs.
No, what I'm saying is, you are saying all 4 cases are anyway. That's why I'm saying, what is the diameter of this defect?
Maximum.
You have said there are 53 major operations. You are still considering hydrocele, that phimosis as major operation? This is not the account of total elective operations.
No,
this is done in elective setting. Yes. But you cannot add this as a major operation. You added this probably. You added the elective operations.
Yes, sir. I have.
No, there are two calculations. Total number of major operations. Sister does not write this as major, and we also don't consider these as major operations. Phimosis is not a major operation, even if give general anesthesia. Previously, people have the notion that any operation under general anesthesia will be a major operation. No. The anesthesia is major, surgery is not major. A phimosis cannot be stamped as a major operation. The hydrocele operation is not a major operation. Okay, so if you take 4 and 3 out, is off from 53. Don't confuse. Audit is a honest presentation of what you are doing in the last month. Discuss how can you improve in the next month. That is the idea of being audit presentation. But unfortunately, Dr. Roy does not bother to come. Dr. Roy is busy. So we are not harboring on data. We are working on how we are going in our practice and how we can improve in our day-to-day practice, because it's a teaching institution. The students should learn what should be done, what should be the next. I don't agree with your mobility of 1 in 1 month. You have done 70 operations and 69 patient has gone smoothly in the post-op period. I don't agree. This failure of your observation, you don't keep notes. Even a speech abscess is a variation. Even a wound days in the post-op period is a morbidity. Prolonged post-op ileus is a morbidity. You start the patient oral fluid, patient has vomited, to restart the IV fluid is a morbidity. We should analyze why this is happening, what we should do. So for morbidity, try to find out the minor deviations. Patient who is having a normal road to recovery is the one group. Patient has major complications and death was one extreme. And some patient having some deviation for the normal recovery, but we take some measures, this patient will do well. So that is what we can try to discuss. If I take 3 units, 150 operations, only 3 morbidity, nobody will believe it. This cannot happen. So many dressings will not have been required. So keep in mind the morbidity also. So we are passing on to the audit presentation for unit 3 of general surgery by Dr.
Sir, can I ask a question?
Yeah. Yes.
Show home in unilateral testicular mass. Why have you done a bilateral orchidectomy?
Oh, acha?
Yes, sir.
So hydrogen treatment is orchidectomy. Why?
Sir, actually, hydrogen was not the main problem. Intraoperatively,
What was the diagnosis? I have not agreed with the, at the end of month. What was the diagnosis of this patient? What is the age of the patient? 74 years. Still his testis is valuable. A 74 does not merit bilateral orchidectomy. What was the pre-op diagnosis?
The pre-op diagnosis, there was a unilateral testicular mass on the left side.
Was it malignant or
Yes,
tubercular?
sir, probably malignant.
Why?
Because it
What
was,
about hormone markers?
hormonal markers.
Alpha beta protein, LDH, HCG.
Actually,
It was not done. You see, you cannot decide about your own way of offering treatment. Patient has got bilateral hydrocele like testicular mass or one side testicular mass. This patient does not merit bilateral orchidectomy. Why you should? What was the histology report came back?
it hasn't come in here.
The month gone. I don't understand. I don't. Milind,
Yes, sir.
what is your
Sir, I
rationality for?
also, sir, I had, sir, for this particular case, sir, I also had some doubts, sir, but Roy sir had planned that way. Sir, there was mass on one side, sir. Tumor markers, I believe, sir, were deranged. Sir, I had seen, I believe, tumor markers were done and they were deranged. Sir, but I did not believe with the bilateral orchidectomy. Sir, I had some
The
doubts.
patient has got a unilateral testicular mass. He is not
Yes,
the
sir.
person to have a bilateral orchidectomy. There is no
Yes, sir,
recommendation like that.
I also, sir, could not understand the need for bilateral orchidectomy, sir. But sir,
If the tumor markers were raised, so the OT should be high inguinal orchidectomy. So
high
how can
inguinal
you do a bilateral orchidectomy
orchidectomy
by
was,
this incident?
yeah, that is a written mistake. High inguinal orchidectomy was done.
Where is the incision made?
In the scrotum.
In the scrotum only, no? He has gone to the scrotum. This is not a right approach to a patient.
Yes,
Patient is
sir. I
74
also
years,
agree. High manner
and
occurred
patient
we should
having
have done that.
40 years will be having same treatment. Even if you consider the patient as a malignant testicular mass, there is no question of approaching the patient to scrotal route. Why should you? There should have been high neurocorrectable.
Yes, sir. I agree with you, sir. Yes, sir.
I understand. Chalo, Prasenjit, please. Keep in mind that for malignant testicular tumor, the approach should be to the high immunolocatomy, not to the scrotal route. If it now comes to malignancy, you open up a new lymphatic spread route to the groin. That is not desirable.
Yes, sir. Yes, sir.
Good morning, our respected faculty members and all our graduates. I am Dr. Prasenjit Basu, and I am going to present the surgical audit for the month of September 2023 for Unit 3, which is under Dr. Emil Shah, Dr. Ahom, and Dr. Siddharth Sankovishi. We have total OPD days 9, total admission day 11, total OPD patient 976, new 692 and old 284. Total number of elective OT days 9, total time in OT, planned OT, lab 42 hours 10 minutes, and open table 36 hours 15 minutes. Total number of minor OT days 9, total time in minor OT is 17 hours 25 minutes, and time in emergency OT 3 hours. Total number of mortality 1. We have elective admission 70, emergency 10, for elective operation we did 49, emergency operation 5. Minor operation 47, mortality 1, and morbidity 2. Elective admission, we have chronic calculus closity, we did lab cholecystectomy for 16 cases. We have polyitic with cholecystectomy presented with obstructive jaundice, we did open cholecystectomy with CBD exploration, and transduodenal sphincteroplasty with primary CBD regular. We have chronic calculus closity with fundal growth. We did diagnostic laparoscopy followed by open cholecystectomy and lymph node dissection and CV.
Was it radical cholecystectomy?
Yes, we sent for frozen section. It comes out negative. Two cases. One at
This came as positive.
No, sir.
Then we have not done that.
The lymph
We-
node dissection is already done.
No. We have started doing it, but once the report came back, it was abandoned.
But this was negative. This is where we had just taken the
Yes. Because the one case we thought that this might be a malignant
Yes,
mass.
sir, yes.
We gone with some amount of dissection, but once the report came back, it was the liver was not resected.
No, sir. Liver resection not that. It is second case, sir. It is first
No,
case.
second case we have done nothing.
Yes, sir. We take the
Second case only biopsy and we came out.
Yes, sir.
First case we open cholecystectomy and we thought of doing lymph node. We have done a complete lymph node dissection. I don't think.
Sir, some lymph nodes are in. So we cleared the area around.
Yeah.
But we will proceed to the formal.
Yeah.
Yes, sir.
Once the report came, we stopped.
Yes, sir.
Second case was
It is CA gallbladder with liver mets.
you see, that was not the pre of diagnosis.
Yes, sir. We yes, provisional.
It is no. Provisional diagnosis or metastasis. Provisional diagnosis was a fundal mass.
Yes.
And CT scan wise, there is no metastatic disease.
Yes.
We decided to diagnostic laparoscopy and we find there is a large mass with multiple liver secondaries.
Yes.
And on exploration, we find that there are a lot of large fixed nodes. Okay. It was not, you see, if you have a beforehand CA gallbladder liver metastasis, there is no role for doing a diagnosis.
Final diagnosis.
No. You are at immediate admission, that is the first diagnosis. Suspected carcinoma gallbladder. So we did not have a FNA proof of malignancy in this patient.
It is the last month. Biopsy reports comes after
That's what I'm saying.
final diagnosis.
Yeah.
Left-sided inguinal hernia with left-sided hydrocele. We did mesh herniaplasty with reversion of sac. In a single case of congenital inguinal hernia, we did herniotomy. Or a single incisional hernia with a SIPOM plus. Bilateral inguinal hernia, we did Princeton mesh herniaplasty for 2 cases. Single paraumbilical hernia, we did mesh herniaplasty. Ventral hernia, we did mesh herniaplasty. Left-sided undescended testing with left-sided orthodoxy. Right-sided rhinohydric with the reversion of shell. A single case. For varianal cases, recurrent appendicitis with laparoscopic appendicectomy for 2 cases. For a single recurrent appendicitis, we did diagnostic laparoscopy followed by exploratory laparoscopy with open appendicectomy with advanced lysis and incisional biopsy from momentum. It is a single case of CA colon with a diagnosed case of adenocarcinoma of descending colon presented to us with features of intestinal obstruction. We did resection and colopolycomstosis and diversion ileostomy followed by left hemicolectomy subsequently in single case. For breast and endocrine, we have fibroadenoma, we did enucleation, and for invasive ductal carcinoma, we did BCS with axillary lymph dissection. These are some miscellaneous cases of right cervical cancer with external biopsy, psoriasis, excision, and a calculus in present at urinary bladder, but on exploration, it is present posterior to the urinary bladder. We did a single case. For emergency, a case with open appendicectomy for 3 cases. We did IDK or variant cases for 2 cases. Emergency admission, we did acute pancreatitis, acute calculus cholecystitis. Cases we did manage conservatively, and 4 cases of left foot cholecystitis with type 2 BMI hypertension, we manage conservatively, and 3 cases of diabetic foot ulcer with development and this. This is a minor operation. We have 3 morbidities and 1 mortality. Morbidity 1, a 35-year female admitted with provisional admission with chronic calculus undergo lapsed cholecystectomy, presented with bile leak from POD1. The drain content increases gradually up to 200 ml on POD2 and POD3. The patient is treated conservatively. The patient is sent for years when stenting on stenting is done. On years, if it is diagnosed as cystic duct stump leak, the joint content reduces after stenting and patient is discharged and to conservative management. Second case, which is initially diagnosed as a mass, fundal mass injury, undergo diagnostic laparoscopy with exploratory laparotomy with incisional biopsy from liver mass. Is presented with hematoma in one side. The suture are removed and hematoma is drained and subsequently secondary suturing done. And this patient is sent to oncology department for chemotherapy. And morbidity 3, we have what 42-year male with provisional diagnosis of chronic calculus with undergo laparotomy with bile leak, intra findings are dense adhesion and frozen callus. On POD1, 200 ml of biliary content is coming from the POD2, it increases up to 304 ml. POD3 patient is sent for ERC and stenting. On ERC system, the stump leak was found. POD4 it reduces after stenting. And POD5 was equal to interpretation collection. Patient is discharged from conservative management. Patient is presented after 2 weeks of discharge. Patient undergo anesthesia after 2 weeks. 2 months leading to venous place. Patient is now doing well. It is presenting the ward. In the mortality one, we have 65-year-old male patient with provisional diagnosis of adenocarcinoma of the descending colon. Patient undergo resection and colorectal transferences and diverse analysis too. After POD2, the patient is doing well. From POD2, the patient is doing well. To gallstone, abdomen and aschematic lead. Re-exploration and left clinical done. Patient is shifted to system from invasive ventilation of POD1 of left clinical position developed sudden cardiac and circumference.
What is doing the first operation?
Sir, in first operation, it is primary resection was done and colorectal anastomosis and done with diversion ileostomy.
Yes.
Yes.
Then in the second operation, hemicolectomy.
Yes, sir.
Then the first operation, there was a leak. Lavage and drain was placed. How do you do left hemi afterwards? In the first operation, patient had a descending colon growth.
Yes.
Resection was done in the first.
No, sir. Resection done, but it primary anastomosis.
No, Prasad, his resection was done in first operation only.
Oh,
You're
you're not
not,
understanding.
you're there in the OT itself.
Patient has got a septic growth in the left colon. The first operation that was done was left hemicolectomy with a primary colorectal anastomosis with a diversion stoma.
Yes.
But this patient has got an obstructing growth. The colon was loaded and there is an anastomotic leak. For that leak, we have taken, there is a frequent discharge of even the main wound.
Yes.
We taken the patient to the theater for re-exploration. We did the lavage and put a drain. We have not done a second resection.
Yes, sir.
What did you resect? देखो ना ठीक से क्या लिख रहा है क्या दिख रहा है. And again, you see, in our end also we have 2 patients of bile leak, very high. If in an institution out of maybe 6 cases there are 4 or 5 cases of bile leak, that means there is very high bile leak. But I analyzed 2 of our patients. Both the patient has got a tear in the cystic duct which was extending into the bile duct. So we try to manage this by putting a suture at the bilateral junction. On table there is no leakage, but it seems that this suture in the cystic duct was not adequate, and patient has. So the lesson is, if you have such tear extending to the bile duct, one can consider putting a T-tube. If you put a T-tube and suture the T-tube over this rain, then you are safe. The risk of bile leakage will be minimal. So you should think how to manage the cystic duct tear. Cystic duct tear can often pass onto the bile duct. That we should identify. Okay, any question from anyone? We can discuss all 3 topics together, no problem. I would request the resident to maintain a register in the ward to write about the morbidities patients are having. What happened in the immediate post-op period, what are the measures given and what came out. So at the end of the month, you can make out, yes, these are the things in the patient who has some deviation from the normal post-op recovery. And you see, there is no disrepute in discussing our complications. That is how we learn. Once you operate, there may be some complications. The art is to know, number one, how to identify the complications. And second is, what should be the optimal clinical evaluation? What should be the investigation you order for situation? And then how do you manage the complications? So these are the 3 important things you should learn. Learning surgical technique is not the end of road. You have to learn the surgical part. You have to know how to identify post-op complications and manage their post-op complications. That is the idea of discussing the whole surgical audit at the end of month. Any comment? Last comment, Dr. Kaur? We can wrap up. Okay, thank you.
Thank you, sir.